Are you ready?
Oh, now we are, thank you.
Okay.
So this is Senate Health and Welfare. We are back live, and we have with us our Director of Payment Reform, Pat Jones. Thank you for being here, and introduce yourself and we'll listen to you.
Thank you. Thanks so much for having me here today. Again, my name is Pat Jones. I'm currently Interim Director of Healthcare Reform for the Agency of Human Services. I was asking Elena if I should mention that I was one of the people who was in her role at one point on my
set it up beautifully.
I worked for the Green Mountain Care Board as well. So I think you all know by now that the Office of Healthcare Reform is really intensely focused on submitting an application for the federal AHEAD model. AHEAD stands for, and I had to work on memorizing this a few times, but it stands for States Advancing All-Payer Health Equity Approaches and Development. I'm pretty sure that they created the acronym and then found the words to fit it. But I do want to say that, you know, it's really important to note that a central feature of this new federal model is health equity. It's infused pretty much throughout the model. So what that does is, you know, including our current federal model, it allows Medicare to continue to be at the table for Vermont healthcare reform. And it allows Medicare to pay differently for health care for the residents of Vermont who are Medicare beneficiaries. And so without participation in a model, we wouldn't be able to do that. We'd be having fee-for-service payments from Medicare. So I want to start by really expressing appreciation to this committee and to the General Assembly as a whole for some of the work that you've done that's really helped to set Vermont up for this potential future model. And specifically, there's two areas that you worked in that showed some really good foresight. The first we've already talked about here was Act 167. That legislation really gave us the ability to explore a future multi-payer model, and specifically to explore the potential for hospital global budgets. And so that's prepared us for the hospital component of the AHEAD model. AHEAD is not limited to hospital global budgets. The other really important component of that model is primary care. They're really looking to support primary care in that model. And so this committee and others and the legislature as a whole worked hard to establish the blueprint expansion. And what, that expansion is doing, it's a pilot, it's a 2-year pilot, but what it's doing is it's really supporting additional integration of primary care with mental health and substance use disorder treatment. We heard from, a couple of different people already today about how important that is. And it also supports integration of identifying and addressing social determinants of health, and that gets to the whole health equity piece as well. So that work that we're engaged in because of the support of the legislature is extremely well aligned with the primary care component of the AHEAD model. I think, they did, CMS, the Centers for Medicare and Medicaid Services, they have an innovation center. They did talk with us about what we're doing in the blueprint, both prior to the expansion and with the expansion. And it looks to me like it that helped influence the design of that component of the model. So I just want to be really clear. Yes, hospital global budgets, huge component, primary care as well. So to that end, when we think about this bill and, how we might make changes and how we approach healthcare reform, it's just, my testimony is relatively brief, but, I think it's really important to consider how any changes that we're considering making in terms of regulation, in terms of structure, in terms of who, responsibility, who's responsible for what. It's important to think about how that might interact with our potential future participation in the AHEAD model. And I want to be really clear, this model is not a done deal. We have to apply. As Devin had mentioned, March 18th is the deadline. I'm on the countdown of, we got a little less than 8 weeks at this point, and it's an intense application. It is a competitive process. CMS has made it clear that they will choose up to 8 states. So that's sort of the application is really the first step. It doesn't commit us to things, but it's, are we interested in the model? Do we get selected? And then, do we come up with an agreement that makes sense for Vermont? And, the first year of implementation would be January 2026. It takes a while for Medicare to change how they pay for things, and it takes a while, I think, to Devin's point, to really work out the details and stand up something like this. So it is not a done deal. I would say that there's more interest from states than we thought there was going to be. In the, what they call a notice of funding opportunity, they specifically call out Vermont, Maryland, and Pennsylvania. But I can tell you that every day I'm hearing from new states indicating that they're going to apply. So, it does look like it will be a competitive process. There's a lot of interest.
May I ask a clarifying question?
Sure.
I just want to make sure I understand. You said that we apply, and then if we get accepted, and then something about, then we see if it makes sense for Vermont. Is that's accurate? So if we get accepted, it's not necessarily that we will take it.
Correct.
Okay. It's a whole other.
Yeah, because we're submitting this application. Just for a chuckle, it needs to be 60 pages, double spaced, 12-point font with, I believe, 1-inch margins. So it's very prescriptive.
Wow.
Sometimes, and it covers a lot of stuff. So sometimes writing succinctly like that can be, can be a challenge. Not that 60 pages is succinct, but that application is the first step. And what they're really after there is they want to know what's the state's capacity to do a model like this. So they'll be looking at things like, what experience do you have with alternative payments, value-based payments? What's your primary care program and Medicaid look like? And again, the blueprint and your support of that has really set us up well for that. What's your sort of data and IT picture? So, they're asking, what's our capacity?
They ask about our IT.
I know.
It's a challenge for everybody, though. We are not allowed.
We're on it, Senator. We're on it.
Yeah. So so they ask about a lot of different things. How ready are states to do this model? And then the other thing is they are giving states that they select up to $12 million to help, stand up this model. It's over 6 years, so it's a couple $1 million on average a year. But there's a little funding there, and so they want to see how are we going to use that. How do we think we're going to use it? What's our capacity? Then they select states. Then you get into the real nuts and bolts about how, there's a formal agreement between the state and the federal government. Our current agreement, the governor, the chair of the Green Mountain Care Board, and the secretary of the Agency of Human Services are all signers of the current agreement. And that's where the real details get worked out.
So, and one question that we haven't, or thing we haven't, well, law we haven't. But in this context, with capitated payments for primary care, and seeing that it's 2026, and then we know there's that gap year. So how do we cover those capitated payments for our primary care folks, and especially those who are currently flowing Medicaid or Medicare, the money flowing through the ACO? So that's a big piece.
So it's a little bit of a dilemma, and you let me know if you want me to keep going a little bit on ahead. But we do have a program for independent primary care practices right now.
Yes.
Through the ACO that has gotten really great uptake, and the practices are really supportive of this. 19 independent primary care practices are participating right now, and that's a good chunk of our independent primary care practices, almost half of the state's independent practices. They're participating. They get a prospective capitated payment that's blended across certainly Medicare, Medicaid, and MVP has a way of participating as well, and that flows to the practices. And there's some, population health payments that they get. There's some, additional payments that they get, but it's revenue that they can count on as a practice. Our current model has been with, an ACO construct has been extended through 2024. CMS has expressed an interest in extending it through 2025 because, again, the earliest the AHEAD model can start is 2026. But they've also made it clear that in 2026, should a state like Vermont be selected and decide to participate in AHEAD, they will not have a capitated program for Medicare in that model. Yet they want to. They want to develop a capitated model, but they can't really. They don't think they can do it.
Yeah, that's.
I know. So I love learning new words. Capitated. I just looked it up. Would it be analogous to like a block grant in education?
It's like a fixed payment for services that are provided, as opposed to fee for service where every service gets a payment.
It's like a member per patient or member per something.
Yeah. And what they do with this is the ACO blends, what they think Medicare and Medicaid can and really in a way should pay. They set a target for how much money should go to primary care, and they base that payment on that. So it's kind of it's a pretty interesting model. And CMS knows about it. Like if you were to say to CMS, a lot of the people there, Vermont, CPR, because the name of the program is Comprehensive Payment Reform, and the acronym is CPR. If you say CPR to CMS, to the people working on this AHEAD model, they know exactly what you're talking about, because for Vermont, because we're the only ones and we've talked about a lot to them and about how important that program is for our.
And it does resuscitate our healthcare.
Yeah, I mean, kind of, yes. I've heard people refer to it as an APT acronym, but they're not quite there yet for that type of a model, but I think they want to talk to us about how that's designed.
Can I ask a question?
Yes.
Since we're talking about all this and not the bill, which is fine.
Sorry.
No, it's totally fine with me. I prefer it. if we don't do the AHEAD model, or we apply and don't get it, or apply and decide it's quote unquote not for us, what are the other alternatives?
I mean, you know, without an agreement with the federal government, it likely means going back to fee-for-service. There's one other model out there that Medicare can, you know, that states can, you know, or organizations, really ACOs can participate in with Medicare, called the Medicare Shared Savings Program, and it's an ACO-based program. But it, you know, it starts to fragment things because, you know, one of the, even though this is about Medicare's participation in our healthcare reform, it's also about multi-payer reform. So this model AHEAD is very focused on Medicaid, also having hospital global budgets, and on Medicaid having an advanced primary care program like the Blueprint.
So that there's no longer, is my understanding, an option to sort of design your own, like we have done in the past. That's not on the table anymore because CMS is not allowing it. Is that correct? Yeah.
CMS has said that they're not interested anymore in single state, you know, like state models for just one state. So that's us, that's Maryland, that's Pennsylvania.
They want outlying states.
They want multiple states in
You're
their
just doing
model.
this to bug me now.
They want multiple states in these models, not together. I've had to really watch my language on that because people have gotten confused.
Yes.
It's not like states band together, have to band together.
Although that might be kind of cool.
It could be
I mean,
interesting.
Medicare for all.
Why
Like-
not have a national healthcare program that actually makes sense?
I mean, to talk about complicated in the current construct, that would be as complicated as this is, it would be even more complicated. So yeah, they are looking for, they are only doing models now that more than one state can participate in. So that's exactly right. So to the bill.
Please.
Okay. So, you know, again, what I was trying to say before I diverted myself was that, you know, if we're looking at making these types of regulatory structural responsibility type changes, it's really important to think about how that interfaces with a potential future model. And I noticed, you know, an example is how we develop and monitor hospital budgets under a new model is going to have an impact on how we regulate hospital budgets. And I noticed that there were places in the bill where, you inserted global budgets, like with an understanding that might be a future direction that we go. And so we're appreciative of that. You know, we're also very appreciative of the reference to collaboration between the different entities and state government. As Chair Foster said, we work extremely closely with the Green Mountain Care Board, and it is not an overstatement to say that we work with them daily. And also the Department of Financial Regulations, who we're working closely with as well, because this has impacts for health insurers and so forth. And so, those relationships are really, really important for a whole lot of reasons, and not the least of which is the complexity of what we're trying to do here and the landscape. We talked a bit earlier about data, and the Green Mountain Care Board holds the all-payer claims database. Obviously at AHS, the health department has data sources. And so, collaborating in a way that we can bring all those things together to improve our knowledge during the regulatory process, to improve our knowledge during, design of healthcare reform, it's going to be really important. And so, I'm appreciative of the fact that you recognize that and that there's a lot of reference to collaboration. There was an Act 167, and it looks like this bill continues that approach. I do think it's important to, reinforce that it's critical to have clarity in roles as well. It's really important to know who's responsible for, designing, for planning, implementation, design, evaluation. And that's not to say that we can't, collaborate on those things, but it's really helpful to know for each aspect of the work, who's responsible primarily. It just helps us plan for the work. It helps us make sure that we can get things done on time. It helps us make sure that we can do things well. We always are looking for ways to work together, and we're looking for ways to eliminate silos. But we're appreciative of the reinforcement of that.
Question regarding this. So in terms of clarity of your role as the healthcare reform director in developing and planning sort of the vision and the reform steps and the policy recommendations, that's you. And then the board as the regulatory and DFR, regulatory entities. And so I think there's an agreement to do that. So it would be helpful to have any language or some collaboration with folks who are here in the room so that we can get to that clarity within the bill. That is critical. But also having the working together concept is also important, and we've seen how that has just grown and been so wonderful during 167.
Yeah.
And I have one other little question for you to ponder on, and I think that this is for all of us to think about, and that is, right now, your term of office as Director of Healthcare Reform goes along with the governor. And one of the concerns that we hear consistently is politics. What would happen if the Director of Healthcare Reform were appointed for a 4-year term? Or a term longer than the political term? And you don't need to answer that because I know where you sit.
Yeah.
But I think others in the room might have some thoughts on it as we might around the table. The pros and cons, just something to think about. That's an end of question, end of comment. But the question is, can you elaborate on, help build the clarity that we need with others who have similar concerns?
Yeah, we're happy to do that. And, I'll be honest and say that, we've reviewed the bill, obviously, but haven't had time to do, a full analysis of impact. As you alluded to earlier, there's a lot there.
Yeah.
And so, I have to sort of reinforce a little bit what Elena said. We're a lean group in healthcare reform at the Agency of Human Services. It's essentially to work on the AHEAD model in addition to some other duties. It's myself and it's the Deputy Director of Healthcare Reform, Wendy Trafton. And we have a couple of other folks who are working specifically on workforce and working specifically on some home and community-based services funding that we've gotten from the federal government, but that's about it. And so, as we, if the bill were enacted in its current form, I'd be remiss if I didn't say that, we would need additional staffing to carry out the additional work that's envisioned. And, so as we get closer to deciding, taking what you requested, Senator Lyons, and really thinking about how roles and responsibilities might be more clearly defined, we can get a little more specific once we
That would be
get
really
there
helpful.
about what the resources.
And similarly, I've asked Chair Foster similar questions.
So, that's pretty much what I had.
Okay.
We'll continue to digest what's in the bill and provide as much feedback as we can. But just want to thank you for your prior work and again for really working hard to set us up for potential future models and for reinforcing the importance of collaboration.
Thank you, Senator Good.
So I'm gonna ask you the same thing I asked the Green Mountain Care Board, is a section by section response to the bill so that I can keep clear about what people actually think of the bill. There's a lot in there and a lot of it is contradictory and unclear, and so I wanna have more clarity from the people who it impacts. I also think that using the term healthcare reform is also overused, just like alignment, because what does that mean? We've been allegedly doing healthcare reform for a really long time, and I think that some of what we call healthcare reform isn't actually healthcare reform, it's just systems change and
System improvement.
well, it's not always improvement. Sometimes it's just change. And so I think that, like the term alignment, we need to be really clear about what we're saying healthcare reform is. I mean, regulation isn't healthcare reform. Regulation is something we should be doing all the time. Reform is something you do, every once in a while. And what we're doing is just running our healthcare system. That in and of itself isn't reform. So now I'm just saying this to you because that's your title.
No,
I'm not claiming that you're.
No, I'm really glad you said that because I realized, like, as we came to the, health reform oversight.
I know, I want to change the name of that one too.
And like deluged that group with 3 hours of testimony on the AHEAD model. And, I'm sure you recognize that, we're being asked to meet with a lot of folks, about this. And I realize that we're not explaining what we're about. So I literally, in the last week or two, just added a slide that says, what is healthcare reform? And, at its most fundamental, it's using public policy to address critical challenges in the healthcare system. And you all know as well as we do what they are. Access to care and insurance coverage, workforce issues, cost of care, quality of care, equity, exactly. So I have a whole list of challenges and then invite people, if it's, a small enough group, to weigh in on what they see as the challenges as well. And, and people talk about payment reform a lot. So, they kind of equate healthcare reform and payment reform. And payment reform is an important component of healthcare reform, but it's a means to an end. The idea of payment reform is to really set up an environment where we end up with better outcomes for the people who need and use healthcare and for the population as a whole. And somebody asked earlier, what's our North Star? Since don't quote me on this because I might have the year wrong, but somewhere around 2008, the Institute for Healthcare Improvement put out what's called the Triple Aim. And it has served as a real North Star for people.
The triple link.
The triple aim, AIM. And so, so the aim is improve cost growth, improve the quality and experience of care for people, individuals, and improve the health of the whole population. Now, more recently, people have added a fourth and a fifth aim to that. The fourth aim is to really improve or bolster the experience of people who are delivering healthcare. So think about the providers as well. And I think, during the pandemic, we really have seen a system under stress. And then the fifth aim is advancing health equity. So making sure that, everyone has access to the care they need and that, and that their needs are being met, their specific needs are being met. So that, if you ask about a North Star, for years, that's been our goal. These are ambitious goals, but it's a way to keep our eye on the prize.
Yeah, I appreciate that a lot. And I mean, as an elected official, my North Star is what's best for my constituents. And my constituents, and I'm going to say all Vermonters, don't understand what the term healthcare reform means. And they are not seeing the results of that of this kind of rearranging the deck chairs.
Senator, I don't want to interrupt you, but I need
Yeah, you
to,
do.
because we are on the floor at 11:30. This is an awesome discussion that we will continue. Appreciate it. And we do want to hear from our other two witnesses, and we'll do that briefly, and then we'll come back to this. And just so you know, I know, Senator Hardy, you've asked for section-by-section comments. I am asking the folks who are in the room to get together and to bring us some recommendations for change that perhaps they can agree on. So whether, and I don't know whether that resolves any of your issues on section by section, but we do need to hear from folks on the thoughts on the bill. So try to put those two things together, that's what I'm saying.
Thank you very much.
Thank you very much. I know we'll be seeing more of you. Great. So Sarah.
Thank you. Sarah
Thank you
Tejal.
for being here.
I am the Director of Government and Media Relations for Blue Cross and Blue Shield of Vermont. I have some high-level comments on the bill, and then I did focus a little bit more than the previous witnesses on the sections that I felt were important to highlight. I can, of course, offer you some written testimony afterwards as well.
That would be helpful.
Sure.
I mean, just give us the high level. We'll bring you back in and as we get into greater detail.
So my high level is pretty detailed, but
That's
we'll
okay.
see how it goes, okay?
You're a detail person.
Okay. So I think our perspective is a little bit different than what you've been hearing. We believe that this legislation is a seismic shift, splintering actually of our state healthcare regulatory and reform oversight, and I don't believe this would benefit Vermonters. The bill adds a massive increase in complexity, administrative costs by further dividing the state healthcare oversight, and doesn't solve the perceived conflict between policy and regulatory decisions. Very few of the provisions in this bill address the main concerns of our citizens, which are affordability, access to care, and solving the sort of complexity of, just the healthcare system. I've heard the desire from this committee to separate policy and planning decisions from a single regulatory body. Such as the criticism of the Green Mountain Care Board being both the cheerleader and the regulator in the ACO. I think that's the genesis of some of this discussion. I strongly disagree with this diagnosis of the problem. No, the Green Mountain Care Board should not be a cheerleader for the all-payer model, the ACO, and quite frankly, no one should be cheerleading in our healthcare system. The very word indicates unquestioned support. If we want the healthcare reform efforts to succeed in Vermont, we need to be constantly vigilant, ask tough questions, and seek solutions. Cheering has no place. Strong regulatory oversight is the best way to ensure the success of healthcare reform. And the example I would give you is the captive insurance regulatory structure. They promulgate strong regulatory oversight in order to domicile captives here. It is the opposite of cheering, and captives value the integrity and stability, which is attractive to the businesses and their customers. That's the model we should be looking for. Every regulatory process is laden with policy decisions. All you have to do is go read some of the rate review decisions, the certificate of need decisions, the hospital budget decisions. Every single one of those is a policy decision in and of itself. If you want Vermont to work towards healthcare reform goals, we need to use the power of coordinated regulatory and policy efforts to move our healthcare system in the same direction. And as a whole, splitting these decisions among different agencies of state government and the Green Mountain Care Board is a recipe for failure. So that's sort of the big picture, and then I'd like to offer.
Can I ask you a question
Yeah,
about that? So
sure.
right now, we have DFR regulating private insurance, and we have the Green Mountain Care Board setting rates and regulating hospitals, but those two are separate regulatory entities. And bringing them together might actually be an improvement based on what I'm hearing you say.
You have heard us say that in the past, definitely. We felt that one of the biggest issues with the Green Mountain Care Board's health insurance rate review process was the lack of connection to the National Association of Health Insurance Commissioners or
That's in the
Insurance
bill.
Commissioners.
I think that's in
Um,
that's hospitals.
No, yeah, it doesn't really change much in the insurance
Yeah.
rate process here. You know, that disconnection, the lack of sort of a systematic across the nation approach has been problematic in health insurance rate review, I would say. This bill doesn't address any of that.
No, it does not, but I was loath to put that into the bill because I hear folks say that we'd rather have DFR regulate everything. So, your comment about having a coordinated regulatory environment is an important comment. Thank you.
Okay, I'll keep moving then. So I'd like to offer my thoughts on why the Agency of Human Services or a possible new Agency of Healthcare Administration is a problematic choice. I've been here a really long time. I remember BISHCA, you know, Banking, Insurance, and Healthcare Administration, and then we carved out the Green Mountain Care Board of that piece. What you're proposing here now is to create a third administrative entity. And some of the work that the Agency of Human Services does, which is implementing the Affordable Care Act, implementing the Blueprint program, so they're more involved in the actual, you know, delivery and implementation and oversight of some of these services. They're not an administrative oversight body. So I think you're creating another set of issues by moving that healthcare reform site.
So the word collaboration needs to be changed. We need to have some very clear lines drawn between reform policy and regulation, but we do need some attachment because we do have different payer and different regulation within the Agency of Human Service. So we do need to have that connection going on. That's a comment. I'm sorry, I shouldn't be making it. I apologize to my committee.
Again, Blue Cross and Blue Shield of Vermont's position is that the policy and the regulation, there's no artificial divide between
Yes.
those. Okay, so just a little bit more about AHS. We believe there's less transparency and process at the Agency of Human Services than there is at the Green Mountain Care Board. Both the Green Mountain Care Board and DFR have multiple administrative roles. I sort of touched on this before, and are not implementing healthcare programs either clinically or as a payer. So Medicaid is a payer program. I'll just jump in. Although AHS through the Medicaid program is a payer, and there is an inherent conflict between the interests of government and commercial payers. So you're creating another area of conflict by moving it over there. This has already exacerbated the shift in costs between government and commercial payers, and without an arm's length regulator keeping a steady downward pressure on prices that are being asked of Vermonters who can't escape the commercial price increases. So we believe that's very important. And then I think I've already made the point about DFR being a professional insurance regulator with the guidance of the NAIC. They have responsibility for consumer protection, market oversight, insurer solvency, and a whole host of other things. So now I'll jump a little bit into the bills. In the sections of the bills, I think it's roughly 1 and 3 through 7 that shift responsibility between the Green Mountain Care Board and AHS. There are some especially problematic provisions, such as allowing the Green Mountain Care Board only to engage in payment and delivery system reform to the extent so directed by the General Assembly or in collaboration with the Agency of Human Services. So you're making everything that the Green Mountain Care Board does subservient to another entity. I think the chair touched on that, and I think that's a huge problem.
But the chair has also touched on a clear demarcation between developing policy and regulation. So that's a conversation that will be continuing. And so what I'm going to suggest at this point, because we are going to become pumpkins, and that is that we ask for you and Michael Fisher to return to our committee and to continue to provide testimony going forward. And then, in addition to which, I have suggested to folks who are in the room where there are there's some understanding of what we would like to do in terms of demarcation of lines, or that you would like to do, that you might be able to bring us some language that is consistent. And then we will continue looking at the bill as it is, and we'll continue the dialogue. So I'm going to ask to postpone your testimony and bring it back when we have the bill back up. And I thank you for your patience, especially Michael. And committee, what I'm going to do is to remind you of next week very briefly, and then we're going to wrap for the day. Next week on Tuesday, we're going to look at the EBT issue related to summer funds for children's programs. On Tuesday, we're also going to look at doula again. We're going to look at healthcare, this bill again, and we're going to, I don't know how we'll be able to fit more folks in, but we'll work on doing that. We will also be moving on and looking at 192, the forensic facility bill again, and continue to work on that, and whether or not we need, and then we'll be picking up S98 on the prescription drug advisory board. So that's our agenda next week. We're going to continue to plow through a lot of the work that we have started. Questions?
I first want to say thank you to Sarah for your very clear testimony. I appreciate that you were not trying to be diplomatic. You were trying to tell us what you thought, and I really appreciated that.